confirm you can hear the sound of my voice.
Yep, I can hear.
I'm going live to you in 5, 4, 3, 2.
Well, good afternoon and good evening. Thank you for joining us. Today's session is about biologics for chronic sinusitis with nasal polyps. The who, when, why, and which one. I'm Bruce Tan. I'm an associate professor of otolaryngology. I'm primarily an otolaryngologist. I do have a joint appointment in allergy immunology, and I'm based at Northwestern University in Chicago. These are my disclosures. Overall learning objectives are to incorporate a patient-centric focus, understanding both the physical, extranasal, and psychosocial aspects of disease burden in patients with nasal polyps, to try and elucidate a best practice criteria for deciding when to deploy endoscopic sinus surgery, when to employ biologic therapy, when to use systemic or nasal corticosteroids, and to be able to differentiate between each of the new and emerging biologic treatments for chronic sinusitis with nasal polyps. First, just an overall understanding of chronic sinusitis with nasal polyps. I'm sure if those of you are listening listening to me are physicians, you know that patients with nasal polyps don't always just come in with nasal symptoms. Certainly there are characteristic nasal symptoms, nasal blockage, facial pain and pressure, discolored discharge, sense of smell loss that are definitional in many ways to patients with nasal polyps. But the burden of disease is more extensive than that. In studies that have looked at and interviewed lots of patients with nasal polyps, we find that there are both those direct physical symptoms as well as indirect ones, such as sleep impacts, physical functioning, impacts of activities of daily living. Certainly sleep and nighttime disturbances are a commonly reported aspect of the disease. A sense of fatigue is commonly reported. Those in turn, either directly or indirectly, may also overall affect a patient in terms of their emotional well-being, social life, impact their work function. It's estimated that as the result of both direct economic impacts and indirect economic impacts, patients with nasal polyps, the cost of the disease exceeds $15,000 per year per patient. So it's not merely a condition of a blocked nose. We've done some work looking at the impact of chronic sinusitis and how to best measure it. We interviewed and obtained responses from over 200 patients with chronic sinusitis. And we came up with this measure called the CRS Pro. I think it kind of encapsulates many of the things that patients with nasal polyps suffer from. It could be condensed into 12 items, which makes this pretty short and fast to administer to patients, but it incorporates physical symptoms, many of the ones that I had told you about. Certainly, we also see some symptoms like coughing are also much more common amongst patients with nasal polyps. There's certainly some sensory impairments, particularly in the sense of smell. And we incorporated some of those psychosocial impacts that we discussed, the ones that were most widely and most severely reported by patients. And you can see the 4 items that we distilled this down into, which are those nighttime awakenings, the fatigue, worry that their condition is going to get worse, and frustration with the chronic condition. We found that this was true of patients with nasal polyps and without nasal polyps. And also we found that this questionnaire correlated quite highly with the SNOT-22, which is quite widely used in the field. But as you can see, you can certainly get away with a lot of the benefits of SNOT-22 with only 12 items. But overall, point being that patients with nasal polyps have symptoms that are the direct physical manifestations, but also some psychosocial impacts, which also drive patients to your office as well as to seek care for the condition. It should be recognized that chronic sinusitis with nasal polyps doesn't exist in a vacuum. It also comes with frequent comorbidities. Certainly one of the most common morbidities, as shown in the blue bars here, is asthma. In studies in the Western world, about somewhere between 50 and 70% of patients with nasal polyps have comorbid asthma. Interestingly, we find that a lot of these patients have adult onset asthma, meaning that a lot of these conditions started in people's adulthood and weren't necessarily something they grew up with. We also find frequent comorbidity with allergic rhinitis, as shown 50% of the patients with nasal polyps have allergic rhinitis. In past studies that also found that they're also more frequently multiply sensitized, meaning that they have allergies to more than one inhaled allergen. There's also a subgroup of patients, depending on the series and depending on whether or not these are tertiary care institution studies. It's reported anywhere between 10 and a quarter of patients may have comorbid aspirin or NSAID exacerbated respiratory disease. These patients have worsening of respiratory symptoms whenever they take an NSAID, but especially aspirin in particular. Almost definitionally, you have to have nasal polyps to have this unusual airway manifestation. But that's also a common comorbidity, and that comes with the aspirin sensitivity, asthma, as well as nasal polyps. Patients who do have this AERD, or amongst the Europeans, they call it NERD, we find that overall the asthma tends to be more severe, meaning that they have increased mucus production, they have increased bronchoconstriction. Some studies have even shown an increased risk of death from the asthma. We also find that if you had this AERD variant, there's also worse sinus disease with more hyperplastic, meaning just, the CT scans of these patients look worse. The mucin in these patients tends to be more eosinophil rich. These patients also tend to have a higher rate of hyposmia and anosmia. In the past, prior to the introduction of biologics, many of the patients who had AERD could be considered for aspirin desensitization. Frequently, this aspirin desensitization was done following endoscopic sinus surgery, and it was shown that these patients had decreases in asthma-related hospitalizations, decreases in medication use if they underwent this aspirin desensitization. But aspirin desensitization came with the fact that these patients had to stay on relatively high doses of aspirin, and there are some incumbent side effects as well as risks that come with long-term aspirin use. I think it remains to be seen whether in the era of biologics to potentially rescue patients who are failing endoscopic sinus surgery, whether or not aspirin desensitization will still be widely used versus seeing if patients recurred and then considering endoscopic sinus surgery in that setting. Quick shift into pathogenic and molecular drivers of chronic sinusitis with nasal polyps. In general, the main type of inflammation implicated in patients with nasal polyps is type 2 inflammation. Type 2 inflammation used to be known as eosinophilic inflammation, but as increasing molecular studies are done, we would say that certainly eosinophils are increased in type 2 inflammation, but whether or not they are the central aspect of disease is certainly to be debated. But type 2 inflammation exists in sort of an ecosystem of different inflammatory mediators. Frequently, it is depicted in a conceptual diagram like this that sort of implicates the different players in this. It's thought that epithelium plays a role in that. Epithelium can respond to things that are encountered in the airway, such as fungi, irritants, allergens, viruses, bacteria, Staph aureus. These agents can activate epithelium to produce alarmins like TSLP, IL-33. These in turn can activate dendritic cells, activate innate lymphoid cells, activate mast cells located with the epithelium, whether it's through the Th2 pathway or through these innate cells like ILCs or mast cells. The key type 2 cytokines, IL-5, IL-4, and IL-13, are produced. These have effects on activating and attracting eosinophils into tissue. They have effects on causing epithelium to produce mucus. They have effects on macrophages to switch into M2 macrophages. They can cause B cells to undergo class switching into IgE. IgE in itself can arm mast cells, and so there's certainly some feed-forward and feedback mechanisms in this pathway of inflammation that perhaps results in the end result, which is a symptomatic patient, nasal polyps, and type 2 inflammation certainly seems to be quite central to nasal polyps. Type 2 inflammation, as mentioned, has some associated characteristic cells. Just to mention that there are other types of inflammation. There's type 1, or formerly known as Th1 inflammation, type 3 inflammation. Type 1 inflammation normally associated with Th1 cells, M1 macrophages. Type 3 inflammation associated with neutrophils and Th17 cells. The different cytokines that are key to each of these types of inflammation are interferon gamma is associated with type 1, IL-17 with type 3. We do find that type 1 and type 3 inflammation are a little bit more common amongst patients who don't have nasal polyps, whereas type 2 inflammation is certainly the most common type of inflammation we see in patients with nasal polyps. There are some, as mentioned, differences in the comorbidities as well, comparing patients without polyps, patients without nasal polyps, but chronic sinusitis do have slightly less frequent asthma, slightly less frequent allergic rhinitis, and certainly they don't have this aspirin reaction. Certain symptoms can clue you into the presence of these different endotypes. We do find that amongst patients with nasal polyps, we do find that the ones who have higher type 2 inflammation are more likely to have smell loss. They are less likely to have headaches or migraines, whereas the ones who have pus do have higher rates of type 3 inflammation in particular. So just shifting gears a little bit into a patient. With that in mind, a patient who's 41 years old presents with chronic congestion, facial pain, reports some increase in postnasal drip, can't smell, has difficulty with sleep. His past medical, I guess his current medications include use of a over-the-counter nasal steroid for 1 year. He has been prescribed an inhaled corticosteroid, and he uses this as needed. He doesn't have a ATP history. He doesn't have asthma, but on nasal endoscopy, nasal polyps are visualized. So the question is, given this patient hasn't had surgery, but there are nasal polyps visualized, what treatment options would you use? Would you give this patient intranasal corticosteroids? Would you advise him to use this exhaled delivery system, fluticasone? Would you initiate a short course of an oral corticosteroid followed by a nasal steroid? Would you administer antibiotics with or without nasal steroid, or would you offer this patient endoscopic sinus surgery? Okay, so majority here offered a short course of oral corticosteroids and a nasal steroids. I think that's a perfectly reasonable choice. And the intranasal corticosteroids was another option. Certainly all reasonable choices. So I'll switch gears a little bit and talk about what we think of as perhaps conventional, or in many terms they use appropriate medical therapy. Standard of care treatment for nasal polyps, I would say, has been under some evolution, but I would say The things that have been previously described and reported to have some benefits amongst patients with nasal polyps are saline irrigations. In particular, the studies actually were done with a hypertonic solution. And it did show that compared to placebo, there seemed to be some benefit from a hypertonic saline irrigation. There was not much benefit if you just used a low volume saline spray. Intranasal corticosteroids have been studied, and there's certainly some randomized controlled trials using traditional intranasal corticosteroids. I would say the effect of intranasal corticosteroids on nasal polyps is relatively small, but those studies were huge, and so they were able to show statistically significant reduction in symptoms and polyp size. I will briefly mention this exhaled delivery system, fluticasone, which I think is a variant on the nasal corticosteroid, but I do think it does seem to reduce polyp size more effectively than traditional nasal steroids. There is certainly use of oral corticosteroids, which in short-term studies does seem to improve nasal blockage as well as sense of smell. And then I'll mention antibiotics were traditionally used quite a bit, even though evidence for it is relatively weak. There does seem to be a small amount of improvement using doxycycline in particular in patients with nasal polyps, and it's thought to be potentially related to the contribution of staph to chronic sinusitis pathogenesis. So this exhaled delivery system with fluticasone is a mechanism that enables you to deliver corticosteroids in the nose, takes advantage of the fact that when you exhale through your mouth, you actually close off your soft palate and can therefore isolate steroid delivery into the nose. Was FDA approved in 2017 on the basis of some phase 3 clinical trials, which enrolled 323 patients with nasal polyps. They used this exhaled delivery system for 16 weeks, which is about 4 months. And what they found is compared to placebo, patients on this exhaled delivery fluticasone had greater reduction in polyp size than the placebo patients. Polyps were eliminated in about a quarter of patients on one side by 24 weeks versus only about 9% on placebo. SNOT-22 scores were improved by about 20 points, which is a moderately large improvement. And based on the symptomatic improvement, the authors said that decreased need for surgery by about 60% was achieved. So that's certainly one option. It can be used consistently. And doesn't seem to result in suppression of the adrenal axis. Certainly, those effects are modest. Oral corticosteroids, in contrast, do seem to have larger sort of improvements in nasal blockage, sense of smell. But they've only been studied for fairly short-term use, so over a 2 or 3 week course. They do seem to improve symptoms of nasal blockage, sense of smell. But there are certainly contraindications to oral corticosteroid use. There are patients with diabetes, patients with glaucoma, where oral corticosteroids should probably be avoided because of their ability to worsen diabetic control and potentially cause acute increases in intraocular pressures. There are also long-term use concerns with oral corticosteroids, and long-term becomes, where does long-term begin? In the nasal polyp literature, we don't have particularly large studies looking at risk of oral corticosteroid exposure. But in the asthma literature, just because they have been using oral corticosteroids in asthma for a longer time, there have been some studies that have looked at large numbers of patients with asthma who had received corticosteroids and compared them to those who didn't receive oral corticosteroids. And they do find statistically significant associations with the following conditions: type 2 diabetes, weight gain, sleep apnea, cataracts, cardiovascular disease, pneumonia, and osteoporosis. osteoporosis being one of the, you can see, largest hazard ratios noted amongst those who received oral corticosteroids. They've also done some dose response relationships and find that for a lot of the adverse events, you start to see significant increases in adverse events when your cumulative oral corticosteroid exposure exceeds 1 gram. 1 gram being, depending on how you use steroids, if you tend to use them as 5-day bursts, you can go over 4 lifetime bursts. But if you use them as, say, like 2-week courses, I tend to use, for example, 30 milligrams for the first week, and then 20 and 10 in the second week. You start to cross that 1 gram threshold at about 3 lifetime doses, which is relatively easy to cross, considering chronic sinusitis with nasal polyps is a chronic and long-term condition. But I agree for that first patient, since he has never really seen oral corticosteroids, he had never really seen he doesn't have a history of sinus surgery. I think being prescribed a short course of oral corticosteroids and then possibly transition to this EDS flu is a reasonable first choice treatment. But in this patient's case, 60 days later, he comes back and he still has postnasal drip, inability to smell, facial pain, and CT is performed on this patient. And it shows fairly extensive opacification of the sinuses. Question becomes, given where this patient is at in terms of what he's been treated with, which therapy would you recommend? Would you recommend an oral corticosteroid, further oral corticosteroids, endoscopic sinus surgery, or would you consider initiating biologic therapy at this point? So amongst the choices, 60% said initiate biologic, 20% said endoscopic sinus surgery, 20% said prescribe more oral corticosteroids. So typically, I would say, prior to the advent of biologics, the options were one could consider a endoscopic sinus surgery, and I still think this plays an important role for many patients. Benefits of endoscopic sinus surgery that it provides instant relief from the nasal obstruction by removing the polyps. It should be noted that even after endoscopic sinus surgery, nowadays it's not just surgery and then, tell patients to have a nice life. It's sinus surgery combined with initiation of a good course of intranasal corticosteroids. There are also now some drug-eluting stents, particularly steroid-eluting. There are ones that can be used short-term after sinus surgery, and there's one that can be used in the post-surgical fashion, and it elutes steroids over about 90 days. But I'd say endoscopic sinus surgery does seem to have durable improvements in polyp size and patient-reported severity. Even over a several-year duration. This is a study that we recently published. We took 90 of our patients who had endoscopic sinus surgery for nasal polyps, and at about 2 to 5 years out, we invited them back in for evaluation of polyp size, radiographic severity, patient severity. And what we found was that even 3 years out from endoscopic sinus surgery, the overall radiographic severity of these patients was still about a third of what it was prior to endoscopic sinus surgery. So their modified Lund-Mackay scores dropped from 30 to about 10 on average. And the SNOT-22 scores were still about half of what they were prior to surgery, just indicating that despite the fact that these patients were, 3 years out from sinus surgery on average, you could still see durable improvements in radiographic and patient-reported severity. So I think for patients who've never seen sinus surgery before, even with nasal polyps, they can improve durably with a good endoscopic sinus surgery. There is a randomized controlled trial that now has looked at this question directly, looking at they randomized basically patients who are eligible for endoscopic sinus surgery to either continuing medical therapy, which included use of a nasal corticosteroid plus bursts of oral corticosteroids, or endoscopic sinus surgery plus continued medical treatment. And this is the results on the SNOT-22 scores, or that patient-reported outcome measure. And what they found was that certainly at the point of randomizations, patients were quite similar in terms of SNOT-22 scores. They had scores in the range of about 50, which is quite typical of a surgical cohort. Patients who were randomized to endoscopic sinus surgery had dropped their SNOT-22 scores by half, so pretty quickly. But as time went by, at 12 months, the patients who continued medical therapy versus those who had endoscopic sinus surgery were actually quite comparable with across the two groups. However, it should be noted one of the limitations of this study was that they used what they call intention to treat analysis, so meaning that patients who were initially assigned to that medical therapy group, if during the follow-up period they elected to undergo sinus surgery, they were still considered in the medical therapy group, even though they had sinus surgery. And in this study, 20% of patients elected to undergo sinus surgery who were initially assigned to this medical therapy group. That's quite a large amount of crossover. It's like, in a placebo-controlled study, if 20% of the patients elected to undergo active treatment, but yet still were analyzed in the placebo-controlled group, I think it would potentially mess up a lot of study designs. The patients who elected to continue medical therapy ended up using about twice as much oral corticosteroids. They had about 587 milligrams of corticosteroid use. So once again, illustrating that corticosteroids can be helpful in the short run. But cumulatively, these patients are a little further along in that cumulative lifetime exposure. Certainly, endoscopic sinus surgery is a difficult thing to mask. So meaning that you could blind these patients to which group they were assigned to. And you could argue that 12 months is a relatively short-term follow-up over in a condition that affects people for years and decades. Another point to illustrate that endoscopic sinus surgery is not to be considered just as endoscopic sinus surgery. It's really endoscopic sinus surgery plus initiation of a good long-term corticosteroid delivery system. This was studied by Richard Harvey, looking at patients who are randomized to just a nasal corticosteroid spray versus nasal corticosteroid irrigation after sinus surgery. And you can see that when they started out, these two groups were relatively similar, but at the end of it, in terms of overall symptom burden, the patients who were on irrigation had greater decrease than the patients who were just assigned a spray. And I believe the nasal blockage and the nasal drainage symptoms in particular were the symptoms that were most improved using this irrigation-based technique as opposed to the nasal corticosteroid spray technique. There have been some economic analyses comparing use of continued oral corticosteroid versus surgery. And also considering the risks of recurrence, overall benefit of surgery, and looking at a time horizon of several years. And what they find is that in some ways, the risk of sinus surgery, the risk of continuing systemic corticosteroid exposure exceeds the risk of surgery depending on what comorbidities the patients has. So in patients with nasal polyps alone, just 0.2 courses of corticosteroids a year starts to be the point that systemic corticosteroids exceeds the risk of surgery. Whereas for patients with AERD, those patients need to be getting more frequent steroids before the risk of corticosteroids exceeds risk of surgery, because these patients are more likely to recur following surgery and still need oral corticosteroids anyway. So for that patient that we mentioned earlier, I would say that certainly the wrong answer would be to continue using more oral corticosteroids in that patient. He had no asthma. But certainly endoscopic sinus surgery could be an option for that patient given where he was at. But then, now we have these biologics. We have different choices for patients. And when do we choose to use a biologic versus when do we choose to use sinus surgery? And I would say they're not clear answers, but sometimes you can look to guidelines, and that's a good place to start. This is a guideline put out, it's a management algorithm put out by a group of allergists and surgeons who sat together and considered the care algorithm. And this is this algorithm, actually, if you look at the original document, it begins kind of where Alex was at the beginning, where he just really presents with nasal polyps. But this part has been excerpted for the patient who has already completed that initial management with a nasal corticosteroid delivery system, possibly with addition of oral corticosteroids if the patient didn't have any contraindications. And what it recommends is that for the majority of patients who have seen some oral corticosteroids, have made a good attempt at managing their nasal polyps with nasal corticosteroids, the majority of patients probably would benefit from endoscopic sinus surgery with continued postoperative management with steroid irrigations. It's only those patients who are failing at that point that they would say, it can be considered for biologics, can be considered for revision sinus surgery, can be considered for aspirin desensitization, or considered for some of those steroid-eluting implants, or further oral corticosteroids. They did mention a minority of patients, and certainly, those of us who see patients certainly see them in our practice, which are that patients who have contraindications to surgery, they're just too sick to be put under general anesthesia. Patients with poorly controlled asthma that perhaps in of itself might qualify them for a biologic, could be considered for a biologic. Or patients who just have fundamental objections to surgery or just don't want to pursue surgery, biologics could be presented as an option. Amongst the Europeans, they also have position statements. This is the EPOS 2021. They said that indications for biologic treatments for nasal polyps would be the presence of bilateral polyps in patients who already had sinus surgery. So in some ways, the European position statement kind of definitionally says that patients who are considered for biologics in some ways have to have had endoscopic sinus surgery in the past, but they also want some evidence of type 2 inflammation, which tend to be relatively easy to hit, so meaning that on their prior surgery, they must have had tissue eosinophils greater than 10 per high part field, need for oral corticosteroids, evidence for significantly impaired quality of life, or significant loss of sense of smell, or they have this comorbid asthma. They said, 3 of these criteria are needed for a patient to qualify. One can potentially look at label indications. I would say this is probably the vaguest. Certainly, if we look at the label indications for the 3 approved biologics, all of them say, they should be adult patients because those were the patients that were studied in the clinical trials. And all of them say nasal polyps. Some of them use the CRS with NP nomenclature. Omalizumab just says nasal polyps. And omalizumab does have some language about inadequate response to nasal corticosteroids, and they recommend it as an add-on maintenance treatment as opposed to perhaps a reversal treatment, for example. But these are the 3 biologics that are now approved, and these are their targets. These are the supporting studies that justify their use and approval by the FDA. The final guideline criteria that one can consider is the Euphoria guidelines, and the Euphoria guidelines recommend that patients should have bilateral polyps. The reason why all the guidelines tend to say bilateral polyps is that amongst unilateral polyp patients, you should always consider whether or not the patient really does have nasal polyps, because sometimes other things besides nasal polyps can look like polyps, things like encephaloceles, tumors. So that's why they tend to have this language requiring presence of bilateral polyps. But they do say that if the patient has no history of surgery but has more of these comorbidities, they could be considered directly for a biologic, whereas the ones who have less have to have a history of sinus surgery. But just a comparison of different guidelines. A lot of these guidelines tend to be produced by European societies, and whether or not they apply here is a little bit more debatable. And so overall, for that patient who's seen oral corticosteroids, what is the best next step? I would say that multidisciplinary consensus statement would say he's a candidate for surgery. Euphoria says that they could potentially go on biologics, being surgery naive. But EPO says that you have to have had prior endoscopic sinus surgery before considering use of biologic treatment. But now we'll get into biologics, which one, and the data behind that supported FDA approval of the biologics. The first biologic that was approved was dupilumab. Dupilumab was studied using this every 2-week dosing, and what they found, and also they had one study put them on dupilumab for 6 months before going off treatment, and then another study looked at staying on dupilumab over a 52-week study. In that study, they did do 2 different ways of dosing dupilumab. One was every 2 weeks, and one was every 4 weeks. And what they found was that if you look at polyp size, the patients who were assigned dupilumab compared to placebo rapidly shrunk their polyps by about 6 months. If they stopped dupilumab at 6 months, they saw a fairly quick return and regrowth of the polyps at 6 months. In the 52-week study, they didn't come off treatment, but it showed that there was sustained reduction in polyp size. There was a statistically significant difference between the every 4-week dose and every 2-week dose, and so the recommended dosing for dupilumab is this every 2-week dosing. Along with polyp size, there was a similar symptom reduction seen in terms of nasal congestion and obstruction scores. But you also see this rebound when patients came off dupilumab. And the patients also, there was a slightly increased improvement in the congestion scores amongst the patients receiving it every 2 weeks. They also looked at it from the standpoint of need for reduced oral corticosteroids or surgery. And what they found was that amongst the patients who were treated with dupilumab, there was overall reduced need for oral corticosteroids or surgery compared to those with placebo, with at the end of 52 weeks, the patients who were on active treatment had a 12.5% chance of needing further oral corticosteroids or surgery compared to a 41% chance amongst patients in the placebo groups. The number of prior sinus surgeries as well as time since sinus surgery didn't seem to affect the results too much, with statistically significant improvement seen in dupilumab compared to placebo, whether or not the patient had prior surgery or not. Although you could say that there may have been a slightly larger improvement in polyp score amongst patients who've had multiple surgeries, as well as those who were more recent from surgery, but because of the subgrouping and all that, some of these actually didn't achieve statistical significance. That second biologic is omalizumab. Omalizumab was studied in a few different ways. They looked at nasal polyp score initially on patients off the omalizumab, then they put them on it, and then they took them off it again. Whereas this one had patients on omalizumab for a full 52 weeks. And what they found is that compared to those who started off omalizumab, you can see that the ones who initiated with omalizumab saw a shrinkage of their polyp score over 52 weeks, whereas the ones who started off and then went on it, you could see that their polyp scores did shrink while they were on active treatment. When omalizumab was stopped, you do see some regrowth of polyps in both arms. And similarly, nasal congestion scores seem to follow that same pattern. They did find that in both study arms, they found that patients on omalizumab did seem to reduce their need for sinus surgery or notice improvements in their symptoms. They use a composite endpoint in those studies. The third biologic to discuss is mepolizumab. Mepolizumab is the one that targets IL-5. And then the mepolizumab studies, they compared patients who were on mepolizumab versus placebo for a period of 52 weeks. And what they find is that, all these studies display their data slightly differently, but you can see that in terms of polyp score reduction, remember this score goes from 0 to 8, although the entry criteria required you to have a polyp score of 5 or greater. But what you see is that amongst the mepolizumab treated groups, these blue bars indicates the ones who have 1 point, 2 point, 3 point, 4 point, or 5 point improvement. You can see a slightly longer tail here, indicating that some patients treated with mepolizumab were more frequently able to notice improvement in polyp score compared to those that were in placebo, which are shown in these gray bars here. And then this is also similar results using that nasal obstruction score, because nasal obstruction is certainly one of the more type 2 biologic responsive symptoms. Using that sort of cumulative hazard model of time since surgery, they do find that patients with on mepolizumab treatment, similar to the dupilumab studies, also saw a reduced cumulative lifetime need for nasal surgery compared to the placebo groups. So how do we begin to compare them? These are, studies that have never really done head-to-head studies, but there are now some systematic reviews looking at the noticed effects in these different phase 3 studies. And what they find is that for certain symptoms, such as sense of smell, dupilumab, for example, seems to improve sense of smell pretty well. All these studies do seem to show a benefit in terms of, but certainly in terms of relative benefit, you'd say dupilumab seems to improve sense of smell the most. Quality of life, all these studies do seem to indicate a improvement in quality of life, a reduction in symptom burden. But in terms of relative risk for these things, you'd say that in terms of efficacy, omalizumab and mepolizumab seem to have an ability to reduce surgery, but remember, the further away you are from one, the better. So dupilumab seems to reduce the need for surgery to a greater extent, and also reduce need for oral corticosteroids to a greater extent. there are now some indirect comparisons that have been published comparing the relative efficacy using published clinical trial data. In these studies, a more negative for nasal polyp score means further improvement. This does seem to indicate that dupilumab seems to result in slightly greater improvements in polyp score and congestion, even compared to omalizumab, as well as improvements in sense of smell, as well as the upset score, which is a objectively measured sense of smell improvement. There's also a overall increased likelihood of achieving a greater than 1 point improvement in nasal polyp score, and increased likelihood of achieving a 1 point improvement in nasal congestion scores. There are now additional biologics in phase 3 clinical trials for patients with nasal polyps. These will be resulted over the next few years, so this space is going to get even more crowded and potentially more confusing. But there is ongoing studies which are studying benralizumab, which is an IL-5 receptor inhibitor biologic, tezepelumab, which is an anti-TSLP biologic, which is targeting some of those alarmins in that earlier conceptual diagram. And there's a depemokimab, which is an anti-IL-5, but a depot form, which basically could be administered much less frequently, in the range of once every 6 months, that will hopefully complete in 2025. Just to indicate that there are quite a few more biologics coming down the pipeline, and we should be aware of these as they complete their trials and become options for treating our patients. Switching back again to the patient who has a previous diagnosis of nasal polyp. This is a patient who has previous diagnosis of nasal polyps. She's had prior sinus surgery and did do appropriate post-surgical budesonide irrigations. But she now presents only 9 months after surgery with congestion, facial fullness, inability to smell. She does have a history of asthma that has been controlled using inhaled corticosteroids, but the CT scan shows that she still has severe opacification of her sinuses. And the question is, how would you treat this patient? Short course of steroids, revision endoscopic sinus surgery, biologic treatment, short course of oral corticosteroids, or a steroid-eluting sinus implant. A lot of people choose biologic, short course of oral corticosteroid. I think all of these are fairly reasonable. So overall, I think the role of biologics has changed this traditional algorithm that we manage patients where, we started with irrigation, went to nasal corticosteroids, oral corticosteroids, and then patients who failed this, then went to have sinus surgery. And suddenly that LK algorithm, I think, is changing now. We now have many more options in that patient population who's failing endoscopic sinus surgery. Suddenly, certain patient populations are more likely to fail the endoscopic sinus surgery and perhaps fail it more quickly. Certainly patients with nasal polyps alone, certainly sinus surgery can be very helpful. Studies have shown that the median years to needing a revision surgery can be measured in decades. Patients with asthma, that time frame can be shorter. They may recur their nasal polyps more quickly. And patients with AERD in particular recur very quickly and end up having a much shorter interval before needing endoscopic sinus surgery. But now in this era of biologics, in that patient especially who has recurred after endoscopic sinus surgery, we now have many more options. For this patient who's recurring fairly soon after her endoscopic sinus surgery, I would say that all the current multidisciplinary consensus statements, including the European ones and American ones, say that biologics can be considered as a management option for these patients. And these patients, certainly discussing with them the various options, whether to continue just their topical steroid therapy, whether to consider revising their sinus surgery, whether to consider aspirin desensitization if they're aspirin sensitive, whether to consider steroid-eluting implants or the biologics, and which one. These are the patients that sort of trying to understand their goals and objectives, what symptoms they're trying to improve, and what kind of treatments they're willing to undertake is important. And these patient population, we should discuss with them what are their choices and which ones they should choose. So basically, amongst in this patient population, after failing, who's failed sinus surgery, after you've talked to them about inhaled nasal corticosteroids, saline irrigations, and oral corticosteroids, one can talk to them about choices of biologics, fluticasone, this exhaled delivery system, or surgical procedure. And especially amongst patients who have failed multiple surgical procedures, the decision-making between biologics as well as repeat surgical procedures, or those corticosteroid-eluting stents can certainly be considered. Patients who have failed standard of care treatment and have other comorbidities which may benefit particularly from a biologic, such as type 2 asthma, especially if it's severe, may particularly benefit from a biologic just because it may potentially target more than one of their comorbid conditions. In terms of a quick table to summarize the relative benefits of each of these various treatment options, you can say that on the left hand are sort of less invasive, less expensive items, but sometimes perhaps do not reduce nasal polyps or their symptoms quite as dramatically. And these include your topical corticosteroid sprays, sometimes with using that exhaled delivery system. The surgical options certainly can have the benefit of greater improvements in symptoms, ability for corticosteroid sprays to get into sinuses, but certainly are more expensive, and certainly there's an incumbent risk of surgery as well as incumbent costs associated with surgery. And on the other end of the spectrum, there are biologics, which are administered via long-term injections. And the upside on them is some of them especially can improve symptoms dramatically. Patients who failed multiple surgeries, where surgery seems to only give them very short-term relief, might be it may be particularly advantageous for those patients, but certainly costs of these medications are quite high. Post-test, which of the following is a more disease-specific questionnaire for patients with nasal polyps? SNOT 22. SNOT 22 is one of the disease-specific questionnaires for patients with nasal polyps. Whereas the SF36 and EQ5D, I would say, are more general quality of life measures, and they're not as specific to patients with nasal polyps. According to EPOS 20, 20 in order to meet criteria for consideration of biologic treatment, patients should have had how many courses of oral corticosteroids per year? I think the EPOS criteria says it's 2 courses, and so a lot of people are getting it correct. So 2 courses per year, or lifetime longer courses for 3 months or greater. Tom's a 45-year-old male with a diagnosis of nasal polyps, and he's taking a medium dose inhaled corticosteroid for his asthma. Has been treated with an exhale delivery system after being previously on just the nasal corticosteroid. Has lost a sense of smell, experiencing lack of sleep. His sense of smell and sleep improved after endoscopic sinus surgery, but since then he has had further recurrence of his smell dysfunction and sleep dysfunction, and has seen recurrence of nasal polyps, which would be appropriate recommendations based on the Euphoria guidelines. Yes, and the Euphoria guidelines are quite permissive for biologic, and in that one they said that type of patient is a appropriate candidate for considering biologic therapy. And I think that is it. Yep, there's one more, sorry. Indirect comparison of available biologics. Which treatment has the greatest impact on improving sense of smell and reducing SNOT22 and need for oral corticosteroids? Dupilumab seemed to have the greatest improvement on those endpoints. I think some of the summaries, things I think I've beaten to death already, but basically, nasal polyps and chronic sinusitis imparts a significant patient burden. When you measure improvement, generally we find disease-specific items such as SNOT22 and CRS Pro seem to better measure the impact of this condition. While systemic corticosteroids can improve symptoms on the short run, one has to consider seriously the long-term frequency and dose and their associated side effects of systemic corticosteroids. There are now 3 approved biologics for treating patients with nasal polyps. There are still no head-to-head trials, but nonetheless, there does have been some analyses looking at relative efficacy that are now published. But in terms of choosing the biologic, sometimes you have to have the conversation with patients and help them choose which type of treatment or modality of treatment is most appropriate for them. Thank you for listening in. Have a few quick minutes for questions if you have any. Okay. Looks like no questions. So thank you very much for listening in. And I hope this improved your understanding of the role of biologics in treatment of patients with nasal polyps. Have a good evening.